Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you for the nice introductions, and thank you for the organizing committee for inviting me. And also I would like to thank Takida for electing me to talk about the possibility of reaching multi-layered remission in Crohn's disease patients. So here is my disclosures. And the presenting agenda for this talk, we will start with IBD principles and target. Then the factor that influence the biological choice, vedolizumab efficacy data in Crohn's disease patients, and we will end up by clinical decision supporting tool. So as we know that the principle of IBD evolved, and by incorporating the personalized IBD, that's mean one size does not fit all, and the smart therapy for the right patients, precision of IBD by optimizing the therapy based on the TDM level instead of the guesswork, prognosis, risk assessment, and disease progressions, and of course the monitoring of the IBD in the term of the short-term targets and long-term intermediate target and long-term target. So as we know that there are two main endpoints in the management of the IBD, STRIDE and SPIRIT, STRIDE for the disease control and SPIRIT for the disease modification. So here is the STRIDE 2, the endpoints in the short-term symptomatic response by improvement of the symptoms more than 50%, and the symptomatic remissions and the normalized of the CRB, those are the short-term. In intermediate target, decrease the fecal calprotectin to the acceptable range, and most of the study less than 250, and the long-term target endoscopic healing, normalized quality, and the absence of the disability. So we can consider the transmural healing, but this is still not a formal target. So this is not something new. We know that there is poor correlations between the symptoms and endoscopy in Crohn's disease patients. So it is better to combine the symptoms improvement with some objective markers like the biochemical or endoscopy findings. So sometimes we did not achieve the target. Either we start the treatment very late, or the therapy is not working, or maybe we did not optimize the therapy based on the level, or we are treating the wrong issues by giving anti-inflammatory medication for stricture or fibrotic disease. So what is a perfect drug? All of us, we are looking for the perfect drug. Perfect drug is the most effective and the most safest drug, but unfortunately this does not exist. So this is the Crohn's disease approved medications. As you can see here, we have 3 anti-TNF medications, 2 interleukin medications, and 1 small molecule zubadasitinib. And we have the gut selective alpha-4 beta-7 vedolizumab. So this is the choice between the medication is not easy. So the factor that influence the therapy of a choice, something related to the efficacy, onset of the action, disease location, presence of extraintestinal manifestation, and prior treatment failure. And the factor related to the safety is drug-related adverse event, disease-related adverse event, need for the concomitant therapy, pregnancy planning, history of infection, malignancy, and also the convenience, mode of the delivery, oral, subcut, IV, or frequency of the dose. We have medication that taken daily basis, or every 2 weeks, or every 8 weeks. And also the access to the availability of the drug and the availability of the TDM level, and of course the cost. So it is very important to assess the risk stratifications, and those patients with age less than 30, extensive disease, those patients with perianal disease and severe rectal disease, deep ulcerations, prior history of resections, and those patients with the damage to the bowel in form of stricturing or penetrating behavior, those are high-risk patients. So the factor that influence the pharmacokinetics of the biological therapy, presence of anti-drug body, concomitant use of immunomodulators, low serum albumin and high CRB, and the high baseline TNF concentration, that means there is high inflammatory burden, and the male sex and the high body size by increase the clearance. So Here, the database of the 3,300 patients showed that at the mid of the 80, there is a peak of the the Crohn's disease surgery, and after that, start to fall down with the introductions of the biological therapy. Now we're going to move to the Gemini trial design. So as we know, there is Gemini 1 for induction and maintenance UC patients, and Gemini 2 and Gemini 3 for the Crohn's disease patients. So this is the study design and endpoints. In the cohort 1, there is 2 arms, placebo arm and anti-flu arm, and the primary outcome was the clinical remission CDI less than 150 at 6 weeks, and the clinical response by achieving more than 100-point decrease in the CDI from the baseline. Those patients that respond at week 6, they will be re-randomized to the 3 groups: placebo, anti-flu Q 4 weeks, and anti-flu Q 8 weeks. So the primary endpoint was clinical remissions, and the secondary endpoint, clinical response and the steroid-free remissions at week 52. Gemini 3, mainly, they include the anti-TNF exposed patients, 2 arms, placebo group and anti-flu group. So here is the result of the Gemini 2. As we can see, the clinical remissions was achieved at week 6 and statistically significant, but the CDI 100 response was higher in the vedolizumab group, but was not significant. Among those patients that respond at week 6, they continue to have the response up to week 52 in terms of the clinical remission, clinical response, steroid-free remission. So this line chart showed that those patients in clinical remissions from week 6 up to week 52. And this is the same for the Crohn's disease activity index response. Here is not something new. There is no signal, and showed that excellent safety profile for the vedolizumab. For those patients, subgroup analysis for anti-TNF naive patient versus the anti-TNF failure population. So the response of vedolizumab in anti-TNF naive patient was 31%, and it was dropped up to 15%. So there is a reduction more than 50% in those patients exposed to the anti-TNF. Among those patients that not responding at week 6, so they, around quarter of them, 25% of them, they will respond at week 52. So allow for 10 to 14 allow for the 10 to 14 weeks for the maximum induction response. So those patients, sometimes they are delayed response, and around 25% they will respond after continue the medication at week 52. So here is some comparative effectiveness. It is a retrospective observational and cohort study, and by using the propensity scoring matching to compare between the vedolizumab and anti-TNF. So as we see here in the overall, there was no difference statistically between the vedolizumab and anti-TNF in the clinical remissions, and in steroid-free clinical remissions, and in endoscopic remission. With the subgroup analysis and the comparative effectiveness based on the disease durations, so those patients that disease duration less than 2 years, the vedolizumab was doing better than anti-TNF, while those patients with the late disease, more than 5 years, the anti-TNF doing better than vedolizumab. So the disease durations, it makes difference when you choose between the medications. This is the persistence of the drug, and it was higher in the anti-TNF group compared to the vedolizumab group. This is a similar design of the study called the evolved Crohn's disease. It is a 24 retrospective medical chart study. They include both UC and Crohn's disease patients. But in the chart here, we see the Crohn's disease, as there was no difference in the clinical remissions between the group at 12 months, 18 months, and 24 months. And also, the achieving mucosal healing in both group vedolizumab and TNF were similar. For the treatment persistent, was doing better in vedolizumab and statistically significant at week 12, at 12 months, but after that, they are similar. So as we know that the first biological therapy is the best therapy, and the second and the third biological therapy, they will decrease the efficacy by 10 to 15%. So maybe here we will see something interesting in the evolved Crohn's disease, that those patients that receive anti-TNF as first line or anti-TNF as a second line after the vedolizumab showed that the efficacy of anti-TNF after the vedolizumab does not decrease, and in the treatment persistent, treatment clinical response, and clinical remissions. And this may help us how to position those medications. So we know that burden disease has, the perianal disease has huge burden on the patients. So around 20% of the Crohn's disease patient, they develop perianal fistula within 10 to 20 years of diagnosis. So here is the enterprise study. It is randomized, double-blind phase 4 study, and they include the moderate to severe active Crohn's disease, draining fistula from 1 to 3. And they are two groups, both two vedolizumab intravenous regimen. The first group is around 16 patients, and the second group is 18 patients, but they include the 10-week dose. So the fistula response at week 22 and 30 weeks is around 46%, and the fistula closures is around 50% at 30 weeks. So as we know that intestinal resection is one of the most important modality in the management of the IBD, and around 70% of those patients, they will have resection during their disease. So the risk of the surgery within 1 year is around 16%, and 5 years is 33%, and reach up to the 47% in 10 years. So this is a prospective placebo-controlled randomized trial called RePreview study, and the around 80 patients, two groups, vedolizumab and placebo group. The primary endpoint was the endoscopic recurrence of the Crohn's disease patients. So as we know that the post-operative Crohn's disease patient endoscopic recurrence is high, reach up to the 90% in those patients without treatments, and those patients that receive prophylactic treatment reach up to the 30%. So from this study, we show that 43% of those patients in vedolizumab, they was in endoscopic remission comparing to the 3% in the placebo group. So it is around 78% patients in vedolizumab group, they had a chance of having lower Rutgert score versus the placebo. So the classification, low risk I0 to I2A versus the high risk I2B to I4. So 77% in the vedolizumab group comparing to the 38% in the placebo group with statistically significant p-value. Regarding the clinical recurrence, there was no difference between the two groups, placebo and vedolizumab group. The CDI rise more than 70 versus the baseline, and this is, as we know that the clinical recurrence sometimes need a time to develop. So mucosal healing, It is an important endpoint to achieve in our patient, and this is what we learned from the CALM study, that those patients with no endoscopic remission, they have more disease progression comparing to the endoscopic remission with a statistically significant p-value. And also the deep remission versus the no deep remission and the disease progression difference between the two groups. So Versify study, phase 3B, open label, multi-center study, addressed this point that patient number is around 100 patients and more than 55% they failed at least one anti-TNF. So in all patients, 25% they achieved the endoscopic response at week 22 with the vedolizumab, and anti-TNF naive patients 28% versus 22% in anti-TNF failure patients. So the endoscopic remissions in all is 12%, anti-TNF 20% versus the 6% in anti-TNF failure patients. So it is very important to know that the complete mucosal healing, it can be different based on the disease location and the disease segment. So the lowest here is the ileum to heal is around 21% versus the transverse colon is reach up to the 51%. And overall, the endoscopic or complete mucosal healing in Versify study at around 15%. So are we ready to treat the Crohn's disease patients with the disease locations and the segment? So the conclusion of the Versify study that endoscopic remissions is 20% in anti-TNF naive patient versus the 6% in anti-TNF exposed patient. So the endoscopic response 28 versus 22. Mucosal healing by disease location in the ileum is around 20%. In the colon, it's from 32 to 50%. And the mucosal healing usually is easier in the colon comparing to the ileum, because we know that ileum usually is complicated by fibrosis and fistulas. So what about the later and early disease? So this is a retrospective multi-center study of the patients with Crohn's disease, around 650 patients. So at 6 months, they compare the rate of the clinical remission and the steroid-free remissions and endoscopic remissions between the patients with the early stage, less than 2 years duration of the disease, versus the later stage, more than 2 years patient Crohn's disease. So those patients with the disease duration less than 2 years, 38% comparing to the 23% in disease duration more than 2 years clinical remission. Steroid-free remission in those patients with the disease less than 2 years is 43% comparing to 14%, and endoscopic healing is around 30% versus the 13%. So the disease duration is a make difference when we choose the medications, and the make difference even for the response to the therapy. So what about the combination therapy? I mean to combine vedolizumab with immunomodulator. Is there any evidence about this? As we know that one of the most advantage of the vedolizumab is the safety. So do we need to combine with immunomodulator or no? So here is the retrospective study of patients including Crohn's disease and ulcerative colitis for both vedolizumab and ustekinumab, with the follow-up is at least for 1 year. And so the primary endpoint was the clinical remission and the response at week 14. And in this study showed that when you compare the combination therapy, vedolizumab or ustekinumab with immunomodulator, comparing to the monotherapy, there was no difference in terms of the clinical remission or clinical response, endoscopic remissions, and the therapy failure. Even this is seen in the ustekinumab. With the subgroup analysis, even those patients that they are not on primary medication, those patients already exposed to the anti-TNF, and we start the vedolizumab or ustekinumab as a second line, so also there was no difference from adding the immunomodulator to the vedolizumab or the ustekinumab to the immunomodulator. So this is the tool, the Crohn's disease clinical decision supporting tool from the Olfactory Consortium, and this tool can help us how to predict a response to the vedolizumab response. So here is the factor. If there is no prior bowel surgery, 2 points. If no prior anti-TNF exposures, 3 points. If no prior fistulizing disease, 2 points. Baseline albumin plus 0.4 point per unit, and the baseline CRP. So as we see here that those patients with the high response, 19 points, the clinical remission achieved in a 38% comparing to 10% with the low response, 13 points, and even the steroid-free remission, mucosal healing, deep remission. So this is the line chart showing that also this tool can help in the Harvey-Bradshaw index, and there is good response in those patients with predictive value more than 19 comparing to the low risk with the point less than 13. So thank you. I think I finished early.